Okay, so let's begin the third MCQ discussion video. Okay, we have 7 questions here, and let's begin. So the first question is the image below with a figure of 8 appearance, okay, is seen in which fungal infection? Okay, so we have here 4 systemic fungal infections, and the histopathology slide is given. They have already mentioned it as figure of 8 appearance. Okay, so figure of 8 appearance, what they're calling is this thing. Okay, so we have yeast cells. Okay, so these are yeast cells with broad based budding. Okay, and they have proper thick walls. Okay, and this is known as the figure of 8 appearance, and this is characteristically seen in basidiomycosis. Okay, histoplasmosis shows narrow based budding. Okay, paracoccidiomycosis shows a spoke wheel appearance. Okay, and coccidiomycosis has sperules, mature sperules in their histopathology. Okay, so figure of 8 appearance, basidiomycosis. Okay, so next question is identify the double reciprocal plots or the line viewer plots. Okay, with the type of enzyme inhibition. So in a normal enzyme inhibition, we plot between the velocity and the substrate concentration, and we get a graph. Okay, for example, if this is the normal graph, and when we do competitive inhibition, so the point is in the competitive inhibition, the km is increased. Okay, so km is increased, Vmax is constant. Okay, so this is the normal graph, but when we do double reciprocal plot of this, we get line viewer Burke's plots. Okay, so these are 3 different plots, 3 different double reciprocal plots, and we'll see which of them is which one. Okay, so the first one is competitive inhibition. Okay, so these plots are derived, so only to remember we'll see. So since this is a competitive inhibition, and you see that the plot is a cross plot. Okay, so they are crossing each other, they are intersecting each other. Cross means fight, which you can remember for competitive inhibition. Next graph is a V-shaped graph. Okay, so V-shaped graph, okay, what you see here is seen in non-competitive inhibition. Okay, and the third one which you see here, you have 2 lines, okay, which are parallel to each other. So these lines are parallel. This corresponds to uncompetitive block. Okay, so we have uncompetitive block or inhibition. Okay, we have 3 different pictures. Cross one or the for fight is competitive inhibition, V shaped is for non-competitive inhibition, parallel 2 line parallels is for uncompetitive inhibition. Okay, next question. Third question is ECG. Below is an ECG of a patient. Which of the following scoring system predicts the risk of stroke in this patient? Okay, so let's see what the ECG is. So lead 2 for rhythm strip for arrhythmias. Okay, for arrhythmia. So what you see is, okay, a narrow QRS. Okay, so 2 block, 3 block, you have irregular complexes, QRS complexes. These are irregular. You do not have a particular P wave, so P wave absent, and tachycardia. This all corresponds to AFib. Okay, so in patients with AFib, if you want to know the risk of stroke, so you have which score? Yes, we have Chadwick score, which is for AFib, and score more than 2 requires anticoagulation. Okay, that is the fundamental of the score. ABCD2 score is for a risk of stroke in TIA patients, in patients with TIA, transient ischemic attack. Hasbled score is a risk of bleeding on patients with anticoagulation. On patients with anticoagulation. As we have discussed earlier, Wells score is for to predict risk of pulmonary thromboembolism. So risk of pulmonary thromboembolism in patients with DVT. Okay, next question. Variable decelerations on cardiotocography is seen below. Is seen in which condition? Okay, so we have 4 conditions, and so decelerations are of 3 type. Okay, so we have early, we have late, we have variable. So early decelerations are seen with head compression. Late decelerations are seen with fetal hypoxia and placental insufficiency, and variable deceleration is seen with cord compression, which is an ominous sign. Okay, and also please have a look at the image based questions with cardiotocography. Okay, next question. The characteristic X-ray sign seen in which type of shoulder dislocation? We have already named the sign, which is light bulb sign. Okay, so when you see this, you see that the shape of the humerus head is like a light bulb. Okay, this is typically seen in posterior dislocation, where the head of the humerus goes back of the acromion. Okay, and forms a light bulb appearance. Okay, posterior dislocation. Next question. The shown maneuver in the picture is so what you see is, so you have the abdomen, and this is the right part. Okay, this is the left part. So the right part, which is there, the colon, okay, the major right colon, the ascending colon, is being pushed up or medially. Okay, and this is to expose structures, to expose the retroperitoneal structures. Okay, so what you are doing is, we are on the right part, we are the right colon, the duodenum, and the pancreas, we are medializing them to expose what? To expose retroperitoneal structures, like in this case IVC. This maneuver is known as Kettlebrush maneuver. Okay, maneuver. Okay, so the answer is Kettlebrush maneuver. What about opposite? Okay, if I am taking this part, the left part, so that is the descending colon, the left part, and I am medializing them, what will I see is, I will see aorta. I can expose aorta. Okay, in this condition, and this is called as Mcq procedure or Mcq maneuver. Okay, the other part is Cockerization or Cocker's maneuver is medialization of duodenum, only duodenum part. Okay, and Pringle's maneuver is to apply pressure at the portal triad or the to in case of hepatic injury, to stop bleeding. Okay, the 7th and the last question is, below is the immunofluorescence microscopy of a kidney biopsy specimen of a patient suffering from. So when you look at this, you see that this is the glomerulus, and the pattern which we see is, you see that the immunofluorescence has seen, and it is quite a linear immunofluorescence, if you see. Okay, so it is very clearly seen as a linear immunofluorescence. Okay, and linear immunofluorescence is seen when the pathophysiology is due to antibody against the glomerular basement membrane, suggestive of Goodpasture syndrome. Okay, so the answer is Goodpasture syndrome. So what about others? Membranous glomerulonephritis and the PSGN, the pathophysiology is immune complex deposition, so they will show granular immunofluorescence. Okay, and IgA will show mesangial, IgA or mesangial immunofluorescence. Okay, thank you.